Okay.
Hello?
Megan en Johan het ook nog unmute te wees.
Okay. Hello?
Can you hear me? Can you hear me?
Is nou live.
Yes, I can hear you.
Oh, perfect. Great.
Okay. So good afternoon, everybody, and thank you for joining. Thank you for taking the time to join us for this installment of our Lunch and Learn webinar series. I think maybe we should just give a minute or a half a minute for those who are just logging on. So I think if we can hang on for a minute or so. I see it is 1 o'clock. Let's just hang on. And then we'll start in a minute. I think we can start. Like I say, thank you for everybody who's taken the time to join us today. Guys, if you can hear me, we're just trying to figure out the audio to make sure that everybody can hear. So we're just sorting out the IT side. Okay, so I see you guys are putting up your hands and sending messages, so it seems that you can hear. If at some stage, for some reason, you can't, there we go. Right. Please let me know if anything changes with regards to the audio. Okay, so let's go. Okay, in today's webinar, Megan, an educational psychologist, and myself, a psychometrist, will discuss the development and practical application of the Conners 3 when assessing for possible attention deficit hyperactivity disorder and its most common comorbid disorders. Megan, would you like to say something at this stage?
No, just welcome everybody, and I hope you enjoy this presentation, and please feel free to ask as many questions as you can to clarify the process or clarify the assessment tool, and so that you can walk away having a better understanding of it.
Great, thanks. Okay, so let's have a look at today's proceedings. We have a short introduction to today's topic, a brief description of ADHD, a discussion around the Conners 3, including the psychometric properties of the checklist, who may use the Conners 3. We look at outdated and derivative versions that are often used, and we look at copyright and the ethical use of the checklist. We'll also show you what the Conners 3 components look like, so that in future you will be able to identify the authentic Conners 3 products from derivatives. My colleague Megan, who you've just heard from, often uses the Conners 3 in her own practice, and she'll therefore take you through a case study and guide you on how to interpret the Conners 3. So, there we go. Dr. Keith Conners was the developer of the Conners range of assessments. He spent his professional career legitimizing ADHD as a disorder. In doing so, he removed much of the stigma that these children are naughty or lazy or cognitively impaired. His range of products primarily focus on identifying problem behavior from as early as 2 years old. Today, we will focus on the Conners 3, a behavioural checklist often used to aid in the diagnosis of ADHD in school-aged children. This checklist is unique in that it also assesses for ADHD's comorbid disorders, such as oppositional defiant disorder and conduct disorder. The checklist further looks at behaviours associated with anxiety and depression, disorders that are often misdiagnosed as ADHD. Okay, we did have a poll in mind, but unfortunately technology today isn't our friend with a poll. We would like to have seen who are our audience, so who's psychologists, psychiatrists and so on. Maybe by a show of hands. Can the psychologists possibly give an indication by putting up their hand? Okay. And then psychometrists maybe? Can you put up your hand? All right. Okay. Okay. So diagnostic criteria as set out by the DSM-5 are used when making an ADHD diagnosis. ADHD can be diagnosed with or without the hyperactivity impulsivity component, and the essential features of ADHD is a persistent pattern of inattention and or hyperactivity impulsivity that interferes with functioning or development. Inattention manifests behaviorally as wandering off task, finding it difficult to focus and persist with a task, and being disorganized. The hyperactivity component is described as excessive motor activity, such as excessive fidgeting, tapping, or talking. Impulsivity is the last component and is described as making hasty decisions without taking the consequences into consideration, especially when the individual could cause harm to themselves. These behaviors need to be present in more than one setting. Controversy surrounds the list of behaviors set out by the DSM-5, and many professionals, like Drs. Russell Barkley and Richard Soul, believe that the criteria are outdated and superficial. Recent research has been able to demonstrate that ADHD is much more complex than an observable list of behaviors, and findings from neuroscience and brain imaging have dramatically changed our understanding of the disorder. It is now seen as a developmental impairment of the brain's self-management system, better known as the executive functions. And complex brain operations are therefore implicated in ADHD. The hope is that brain imaging can help diagnose ADHD in the near future. Okay. In South Africa, the prevalence of ADHD has been estimated to be at 5% of the population. This is consistent with worldwide estimation of the prevalence of ADHD. However, according to many widespread sources, the incidence of diagnosis of ADHD has been on the rise for the better part of the 2 decades. According to data gathered in 2013, the CDC estimated that 15% of high school-aged children have been diagnosed with ADHD, and that the number of children on medication for the disorder has soared to 3.5 million from 600,000 in 1990. Dr. Conners likened this tremendous increase to a national disaster of dangerous proportions. Dr. Conners also felt that the number of children on medication was unjustifiable. This increase in diagnosis has been attributed to many factors. So from professionals being better equipped to diagnose ADHD, to the way in which we live today, to pharmaceutical companies having very successful marketing campaigns. A more recent review of the CDC's data of the last 20 years indicate that ADHD diagnoses have risen from 6% in 1997 to 10% in 2017. In that time, ADHD diagnosis increased for both boys and girls. About 14% of boys were diagnosed with ADHD in 2017, compared to 9% back in 1997. Meanwhile, diagnoses in girls hit 6%, up from 3% 2 decades ago. This increase has also been attributed to a better understanding of ADHD, but also to possible unwarranted diagnosis. Another reason may be that due to research, the diagnostic criteria has been broadened. It's now also possible to diagnose children younger than 6, and it's been found that ADHD is not outgrown as previously thought. And all these factors increase the statistics surrounding the diagnosis. To curb possible overdiagnosis, it's therefore imperative that well-researched assessments like the Connors 3 be used in the process of diagnosing ADHD. In the guidelines released in 2013, SASOP describes a comprehensive process that psychiatrists ought to use in psychiatric assessments. Together with other checklists, they mention the Connors 3 as a rating scale that can be used during such an assessment. Another very important point that the guidelines highlight is that the diagnosis can never be made based solely on a rating scale. The Connors 3 manual itself also affirms this. A cornerstone for diagnosing is a clinical interview, and this is true whether you're a psychiatrist or a psychologist. The guidelines emphasize that there is a significant risk of misdiagnosing other psychiatric disorders as ADHD, particularly anxiety, and it's important to explore the child's emotional symptoms. Then, according to the Connors 3 manual, ADHD is a diagnosis that is familiar to most people, even to those not involved in mental health assessment and treatment. And because of the prevalence and widespread media coverage of ADHD, many people feel that they know what the manifestations are. Professionals in the field realize that accurate identification of ADHD is not obvious or straightforward. It's critical to have appropriate assessment tools based on both clinical work and research findings that contribute towards accurate diagnosis and treatment planning. The Connors 3 fit the above description and therefore helps clinicians determine if a child is having more difficulty in a given area than other youth of the same age. This developmentally referenced guideline helps reduce overdiagnosis by allowing for a direct comparison of an individual's behavior with characteristic behavior found in a normative sample. The Connors 3 with DSM-5 update, released in 2015, is a product of more than 40 years research in the field of ADHD. It aligns with the classification of ADHD in the DSM-5. And the Connors 3 is unique in that it assesses not only for symptoms of ADHD, but also for features of its comorbid disorders, such as conduct disorder and oppositional defiance disorder. In addition to these, the assessment also contains screener items for anxiety and depression. As mentioned in SASOP's guidelines a little earlier, anxiety disorders can often be misdiagnosed as ADHD. The Connors 3 also contain a 10-item ADHD index as well as a global index. The Connors 3 ADHD Index, or Connors 3 AI for short, is included in the full-length Connors 3, or it can be purchased separately. The 10 items contained in the Connors 3 AI are proven to be the best in differentiating between youth with ADHD and youth in the general population. It can be used for screening individuals, for monitoring treatment plans, and for measuring response to intervention, or when time is limited. The Conners 3 Global Index, or the 3GI, is a fast and effective measure of general psychopathology. It includes the 10 best predictive items from the original Conners rating scales with up-to-date norms. This tool is also ideal to determine next steps that you need to take in further examination and treatment monitoring. Are there any questions at this time? Megan, would you like to add anything here?
No, Andrea, I think you've done for now. I think it's, yeah, a good background information.
Okay, so then, moving on. The Conners 3 has both full-length and short forms available. The latter is mostly used for research. The full-length forms take about 20 minutes to complete and are given to the youth themselves from around 11 years onwards, their parents, and or their teachers to complete. It's essential to gain insight into the youth's behavior in different settings, as an ADHD diagnosis can only be made if the symptoms are present in more than one setting. The Conners 3 forms can be administered paper and pencil and then hand scored, or administered and scored online, or by a software program. The last two scoring options provide the professional with a selection of 3 comprehensive electronic reports. The 3 electronic reports mentioned are assessment reports, which provide detailed information about scores from a single administration, presented both numerically and graphically. And individual scores are compared to those in the normative sample, and elevations at the scale and subscale level are indicated. Progress reports compare the results of 2 to 4 administrations for the same individual to measure changes over time. These reports are ideal to use when monitoring treatment and intervention effectiveness. Comparative reports combine the results of different raters to provide an overview of an individual's scores from a multi-rater perspective. This highlights potentially important inter-rater differences in scores. The normative sample of the Conners consisted of 3,400 youth from the general US and Canadian population, evenly distributed by age and gender, and racial distribution closely matched that of the US population. The Conners 3 has not been normed for our local population. However, the Conners 3 is based on DSM-5 criteria, which is standard across the world. Local norms would be helpful in estimating treatment, but not for changing the diagnosis or influencing the diagnosis. Okay. The Conners 3 has excellent psychometric properties and can be used with confidence as part of an assessment process. I'm going to give the audience a little while to read through the next 2 riveting slides, which describes the reliability and the validity of the Conners. For a more detailed description, please read the Conners 3 manual. Okay, who can use the Conners 3? The question has sparked numerous debates, both internally at JVR and externally with the HPCSA, as well as clients from different disciplines. Recognizing that this checklist should be used by all professionals who might be involved in diagnosing ADHD, such as psychiatrists and pediatricians, JVR physically took the components of the Conners 3 to the HPCSA and met with the now former chairperson of the Psychometrics Committee so we could receive confirmation on who may purchase and use this checklist in South Africa. The HPCSA continues to restrict the use of a diagnostic assessment like the Conners to psychologists only. This causes a tremendous problem for the other professionals, as they might then have to resort to using inferior products. According to the Connors 3 manual, users include psychologists, clinical social workers, physicians, counselors, psychiatric workers, and pediatric and psychiatric nurses. The manual further sets out stringent conditions of who may use the assessment. If clients in Africa would like to purchase the assessment, international criteria as set out in the manual will apply. Following the above dilemma, many professionals resort to using free online versions of the Connors or older discontinued versions thereof. Some practitioners have simply retyped the questionnaire into an Excel document with no reference to the Connors, essentially claiming it as their own checklist. Creating a behavioural rating scale is not easy and as simply collating a few behaviour-related questions. Research, as with any other psychometric test, is imperative. And as mentioned earlier, the Connors has 40 years of research with proven reliability and validity to support its findings to accurately aid in the diagnosis of ADHD. If it effectively differentiates between ADHD and other possible pathologies, using your own or retyped questionnaire contributes to the overdiagnosis of ADHD and may harm the youth that you are assessing. Megan, do you have anything at this stage?
Yeah, Andrea, I wanted to say there as well. Not only is it the fact that there might be overdiagnosis and stuff, but also the unethical use of it and using copied assessments and retyped questionnaires and things like that might actually result in people losing their practicing license. And I think also the wrong people having access to the assessments. And this is a difficulty that I always find in my practice is when parents come to me or teachers come to me and they say, I've got this off the internet and this is my child, or I can see that this is the problem with my child in the class. I found this and this and this difficulties. They're definitely ADHD. And unrelated to ADHD with the symptoms that a child's presenting with. So yeah, please be careful with the ethical use and using Connors assessments appropriately.
Thanks. Yeah, I must be honest, I can confirm that from personal experience about children being kind of looked at their behavior and slapped with a label on their forehead.
Exactly. And as easy it is to label a child, it's so difficult to actually for that child to get rid of a label.
Yes, no, that's very true. Okay. Multi Health Systems Inc., or MHS for short, is the publisher and copyright holder of the Connors 3 and all previous versions thereof. JVR Psychometrics, us, we are the sole supplier of the MHS assessments and by implication the Connors 3 also in sub-Saharan Africa. The Connors 3 is a copyrighted assessment and can therefore not be copied without the explicit written permission from MHS. This means that the assessment may not be retyped into any format and it cannot be given the name like Connors, simply being misspelled. This is still copyright infringement and punishable by law. Using a discontinued version of an assessment places the practitioner at risk of making an incorrect diagnosis. And there is often a very good reason for a publisher to discontinue an assessment, such as outdated norms, or that the assessment is based on old research and new findings prompt a revision of an assessment, like with the Connors 3. It might be frustrating and expensive to purchase new revisions, but these updates are essential so that assessments can keep up with the latest research findings. Megan, anything you'd like to add?
Yeah, Andrea, I think in that regard too, that's where the online use of the Connors assessment is actually very cost effective because what I found in my practice is that I haven't had to, buy a new Connors assessment because I can just use the online assessment and only be paying per user. and then have to just get the manual, which is actually a lot more cost effective in the long run. And also the fact that you're staying up to date, staying up with all the relevant research, and the fact that the CONUS 3 is actually in line with the DSM-5. So that's why it's crucial to be able to use updated assessments.
Thank you. Okay, so what does the CONUS look like? Here are some images to help you identify the CONUS 3. Ensure that all the components are in color and that the MHS and CONUS logos are present. The DSM-5 endorsement can be located on the top right corner of the quick score forms. That's the picture on the right side of your screen. And on the left side of your screen is the manual. The quick score forms are the hand scoreable version of the CONUS. After your client has completed the questionnaire, tear off the perforated strip and score using the steps as set out in the manual. The online version of the CONUS is available on MHS's Mac platform. We open a portal for the psychologist and you send out the invite to your client to complete the CONUS 3 online through your platform. You will be guided through the answering, or your client will be guided through the answering process on the portal. And once your client has completed the CONUS 3, an electronic report of your choice, the 3 that I mentioned a little bit earlier, will be sent to your secure email address. Interpretation of the reports are then made using the manual as guidance. So on the left side is the online form. That is what it looks like when your client completes it. And then on the right is a sample of what the electronic report looks like. And that's what you then receive in your inbox or on your platform.
I'm actually going to go through that in a lot more detail now, Andrea, with the case study that I'm going to be discussing. But I think sometimes when people think, oh, online form and electronic and technology and all of that, it can be quite overwhelming, but it's very, very user-friendly, very simple to use. And I have not had one difficulty with one of the parents that I've sent it to or one of the teachers that I've sent it to. And it's actually quite nice because they you get your feedback quickly as opposed to waiting for teachers to fill in and sending the forms back to you and it going to and fro. This is a very quick way. The online forms are a very quick way to do it, and very comprehensive as well, the report. But we'll discuss it in more detail now.
Thanks, Megan. Yes, I do feel like I've done a lot more talking than I usually do. Before I hand over to you, I just want to make our audience aware that October, I think next month already, is ADHD Awareness Month. So when you have time, please have a look at the organizers, the ADHD organization, Attention Deficit Disorder Association, and then CHAD. I see that they say that they organize many different events around the world. I'm not sure whether anything is being organized on this side of the world. People often forget that we are down here. But let's see if there's anything that we can do, or if there's an article or an opinion or a blog piece that any of our listeners would like to send through to us, please do so. And with that, Megan, over to you.
Thanks so much, Andrea. All right, so basically my side, Andrea, I actually didn't get a poll of how many psychologists and how many psychiatrists we're chatting to.
Unfortunately, the electronics of the poll is not on our side today.
Oh, okay, so you can't see that information either.
No,
okay.
not that I can see.
Oh, okay, perfect. So from my side, all I'm going to be doing is really taking through a case study that I done with a little boy named Rudolph, using the CONUS assessment. And basically, this is to just give you more of a practical approach. Andrea has taken us through a very detailed description of the background of the CONUS and all of that kind of stuff, whereas I'm going to talk about a lot more of a practical approach and help to hopefully give you guys more insight as to how the assessment works. So the case study that I had was this little boy, Rudolph, who came to me. He was 10 years, 8 months old. He was in grade 4, and his reasons for referral. And I think in grade 4, you often find that up to now, children have been relying a lot on memory
And although you can diagnose ADHD from the age of 6, it's sometimes better to give children a little bit more of a chance to see if it's more coping in school and things like that. But often when you get to grade 4 is when the wheels come off and a lot of assessments happen. So Rudolph's marks were deteriorated, and he was also struggling with his reading fluency, understanding what he's reading. His retention of information was also not very good. He was starting to fall behind in his schoolwork, and he didn't seem to maintain focus in class. That was being reported by his teacher and then also by his mother, who was getting very frustrated in afternoons because he wasn't maintaining focus during homework time. He was very disorganized and lost things from school jerseys to papers that he was supposed to do, and he often used to make careless mistakes. So all this information I obviously got through interviews that I had with the mom and the teacher. And from looking at all of this, we might think, oh, okay, ADHD seems like a strong possibility. But what we could see is that all these difficulties that Rudolph was having were starting to interfere with his daily performance, his deterioration in classwork and his tests, and that his problems were pervasive. They were evident in all of his learning areas, and it wasn't just in one specific area, and it wasn't just subject specific. So we knew at this stage, well, I knew at this stage that it wasn't possibly just a specific learning difficulty that he had, for example, a maths or a reading difficulty. Okay, and it didn't appear here that he had a strong social or emotional difficulty. From what the teachers and the mom were saying, it didn't appear like there was a strong social and emotional difficulties that he was having. Okay, then can you move to the next slide, Andrea? Okay, so in terms of after you have given the assessment, I've taken out actual parts of the Connors assessment report, and I've actually showed you how specifically it does interpret it for you. So once you've got the assessment report, so anyway, I decided to use the Connors assessment report as I kind of thought ADHD was a likely probability, and so therefore went ahead and used the Connors assessment report. So when I was going ahead and looking at an interpretation of the report, it starts off then by assessing the validity of the rating. So the first thing you need to do is, when looking at the Connors assessment report, is looking at your positive impression, looking at your negative impression, and looking at your inconsistency index. So as we can see in this case, with Rudolph's assessment, there is no inconsistency index, is negative or any signs of a negative or positive response style. So we knew that the validity of the ratings were good. Okay. The next part of interpreting the scale, Andrea, is looking, then you take a look at the content scales. So now if we look at the content scales on the left-hand side, we can see that these are the content scales. It says the Connors 3P content scales, T-scores, which the P there stands for parent. So we can see that's the way that the parent has reported Rudolph's behavior to be. Then on the right-hand side of the screen, you will see the Connors 3T content scales. The T there is showing the teacher's interpretation of the content score, of Rudolph's behavior. What is nice here, and often it's nice to take a look at both the parent and the teacher's scales, to be able to make a triangulation and to be able to look at the correlation between the information that you get from the parent who sees the child. So for example, Rudolph's mom could see him in his home environment, could see him in his homework environment, and could see any stresses that he had with regards to how he was coping towards school and his attitude towards school and things like that. And then the Connors 3 teacher scales also looks at the same sort of content scales, but obviously more focused on the learning environment at school, where we can see how Rudolph performs at school. So I must say, often in my interpretation, I always look at the teacher's scale as, my personal opinion, I always kind of take that with more weighting as opposed to the parent scale, just because of the fact that they're looking at the child more in a learning context, and whereas a parent is often a lot more biased according to the child, or a lot more overly sensitive of the child, and puts a lot more pressure. So you might see heightened results from a parent side, or actually sometimes lower results, because they don't try avoid problems or try and not look at their child and take ownership of any of the difficulties that they have. But really nice to get a comparison between the teacher and the parents. Obviously Rudolph was younger, so he didn't actually fill in a self-evaluation form, but then I used the triangulation between this information between the parents and the teacher. We can see here that there were strong correlations. Although the mom reported learning problems and inattention to be higher, the teacher also identified inattention and learning problems as to be the two areas of the two content scales that show where Rudolph has most of his difficulties. You often find that sometimes parents are not so aware of their child's behavior in school, and will say, like, my child can concentrate through a whole movie. And that's very passive. The child watching TV is very passive, whereas the child looks more, whereas the teacher looks more at a child in a learning environment where many of executive functions have to be used. And so that's why it's nice to also get the triangulation of both of from the parents and the teacher. Okay, so then we have a look at the content scales, and we're able to get the information out of that. Next, we look at then, with regards to the interpretation, as we look at the DSM symptom scales. These symptom scales show here, once again, that the likelihood or the probability of Rudolph presenting with ADHD inattentive type is really high. And the ADHD of hyperactivity impulsivity presentation is also high. Okay, high obviously because it's marked in red, so it's above an average score of 60, what we would look at. I have now just interpreted, I've taken just the teacher scores of Rudolph's behavior, and I'll be discussing those more in detail now. Okay, so once then you've got the DSM-5 symptom scales, you then take and examine the overall profile scores of the child. So here we can see for Rudolph that according to his teacher, his inattention is elevated, very elevated, and then the report actually gives you the correct common characteristics of the high scores. So may have poor concentration or inattention, may make careless mistakes, may be easily distracted, may give up easily or be easily bored, may avoid schoolwork. And if you can remember earlier on, these were a lot of the symptoms that the mothers and the teachers were reporting that they were seeing with regards to Rudolph's behavior. We can see there too that his learning problems were also very elevated scores, which shows he had academic struggles with regards to his reading, writing, and or his maths. And he may have difficulty learning and remembering concepts, which is exactly what we found in terms of the clinical interview that I did have at the beginning of the process. Okay, those are two of his biggest area of concerns. We can see that his executive functionings are also high, as well as his hyperactivity and impulsivity, but not as high as his inattention and learning problems that were reported. All right, so once you've seen the content detailed scores, the next process would then be to look at, let's go on to the next slide, would be to look at, so this is just once again a summary of all of the detailed scores of Rudolph's detailed scores. Next one. Okay. Then this it actually gives a symptom count, which is actually very interesting to see once, which shows us how Rudolph's symptoms correlate with the DSM-5 diagnosis. And that's why the use of the CONUS 3 is fantastic, because it's such an up-to-date assessment where it relates to the DSM-5. And as you can see here, Rudolph presents with at least 6 out of the 9 symptoms. Okay, so his symptom count as indicated there is 7. And there we can see that the probability and likelihood of him having ADHD is high. Next one. Okay. Then what's you actually, the next part of the process, once you have done the assessment, would be to examine the overall profiles of the scores, okay? So we'd look at, excuse me, we'd look at the impairment scores, where we can see that the level of impairment that Rudolph's difficulties are having with regards to his academic life, his social life, and his home settings is presented below. So as we can see here, his academic impairment and the results that he presents with, or what's being reported on, you can see that the impairment is pretty much or often, very often happening in an academic society, in his academic environment. So we can see that because it's having such a negative impact on his academic environment, the serious intervention needs to be considered. We can see that Rudolph's impairments that he reports with aren't having a huge negative effect on his social or his home environments. Next. Okay. Thanks, Andrea.
Can you see the next slide? It says Connors 3 Global Index.
No, I can't see. Oh no, now it's just come onto my screen. Yeah. The next part of the interpretation would then be to look at the Connors 3 Global Index. So this is what the report gives you, which it summarizes the ratings with respects to the global index that Andrea spoke about earlier. And then it gives your scale scores, your guidelines, your T-scores, your guidelines, and then the characteristics. So here we can see that according to the global index score, Rudolph presents with restless and impulsive behavior, and his total global index of ADHD is also elevated. And so that's the information that we're able to get there and how we interpret it next. The next we move on to is you're able to also from the report is to take a look at all your different item level responses. So you can look at all the different items that contribute to the elevated score. So you can see which individual items have higher ratings, and then you're able to use that as part of your intervention process. So here we can also see that according to the anxiety screener items, that although in the beginning teachers and parents didn't really think that anxiety was something that was impacting Rudolph in his day-to-day functioning, or they didn't really identify him as being an anxious child, here we can see that in his anxiety ratings and the screener items that we get, his worries and his trouble concerning his worries, and he's irritable when he's anxious, is a higher rating, okay, which shows us here that actually Rudolph has higher levels of anxiety than would be expected of a child, a peer of his age with no level of anxiety. We can see that with regards to the depression screener, Rudolph didn't present any results, any higher or behavior with regards to the specific items related to depression. So there's no raised concerns with regards to depression on that side. But once again, we need to look at these anxiety items and realize that some intervention needs to be incorporated into the treatment process. Thank you. Okay. This assessment also allows you to look at any severe conduct critical items. Once again, like Andrea said, this assessment is able to look to see if there's any conduct disorders available, your oppositional defiant or any other conduct disorders available that the child presents with. And it also provides any additional questions or information that the assessors provide about the child. We can see here that absolutely no conduct critical items or any behaviors with regards to conduct disorder were reported with regards to Rudolph from both his teacher and his mum's side. Okay, so this, I just wanted to basically give you a summary of how you would take the report, how you would look at the report, how you would interpret the report, and how much information you can actually get from the Connors assessment report. Then what you can also do is nice, it's to integrate the results. Okay, so you can look at the results, you can consolidate the results from a single rater. You look for all the similarities and the discrepancies within a report. And from my side, I was able to compare the findings across the different raters, so between the parents and the mum, the parents and the teacher. And also then what I did was took all the information that I had, and I took in all the other additional sources of information that I had, the clinical interview, the observations that I had during tasks, other tests. I looked at his schoolwork and his reports, and from there I was able to decide on what sort of intervention process I was going to use. Okay. So then once what I basically took then, right, we can see that Rudolph has inattention and more concerns than average. He does demonstrate hyperactive and impulsive behaviors, and he does present with a learning difficulty and has academic struggles. So from this information, I was able to then triangulate the information from other assessments. Like Andrea said earlier, you don't just use the Connors assessment in isolation without other information. So I took this information and triangulated with other assessment that I had used to make a diagnosis of ADHD that Rudolph presented with. Let's go on, Andrea. Okay, that's just a follow-on. I've discussed that earlier, that he doesn't present with any oppositional defiant behavior, any conduct problems, or no defiance and aggression. So this was not incorporated as part of the intervention process. Okay, that once again, I was just showing you an example of what you can see on the report. And it does provide what follow-ups are recommended. So here we can see that Rudolph required follow-up with regards to his inattention, his hyperactivity and impulsivity, some learning problems that he has, and we can see according to the DSM-5 symptom scale that he presents predominantly with inattentive presentation and hyperactivity presentation. So we can see that there is a combined presentation of ADHD there. According to the screening items, to follow up on anxiety more so than depression, so that was part of my planning for my intervention process. Thanks, Andrea. Okay, so we can see here the probability of Rudolph having ADHD is likely. There was strong supportive evidence for the possible diagnosis of ADHD inattentive type and combined type. He presents with learning difficulties, so basically his level of impairment in the academic area was often. He has raised levels of anxiety, and he currently does not present with any other defined behavior or conduct problems. So here, the type of intervention the type of assessments that I used to get to where I was at, I included a WISC assessment, which once again gave his IQ score, because you wouldn't diagnose ADHD without taking a look at the holistic development and the holistic approach of a child. So I was able to look at his IQ scores. He presented with an average IQ, but I could see there that his processing speed and his working memory were compromised. And as Andrea said earlier, that ADHD now is your developmental impairment of your brain's self-management system, so looking at the executive functions. So another great assessment that I used, and that I triangulate often with the Connors assessment, because it focuses, because with ADHD diagnosis, we need to start looking at the executive functionings of a child, is the CEFI assessment. It's called the Comprehensive Executive Functioning Inventory. So this was another assessment that I triangulated to be able to get the information I used to make the diagnosis and to decide on the intervention process. The CEFI assessment, I know that isn't the focus of our discussion today, but it is a great assessment for the executive functions that looks at attention, emotional regulation, flexibility, inhibitory control, initiation, organization, planning, self-monitoring, working memory, all of these executive functionings that are crucial to look at with regards to the brain self-management system, which is in essence how ADHD presents itself. So the two assessments talk nicely to each other and provide a lot of information to each other. So on this, from the CEFI assessment, I also found that Rudolph's attention, his emotional regulation, as well as his initiation, organization, and planning, as well as his working memory, were all areas that also required intervention, which basically enhanced or supported my diagnosis of ADHD, just to once again support the fact that Rudolph requires a lot of assistance with many of his executive functions. So from that, all those assessment results, I was basically then able to see that Rudolph needed concessions, and concessions were implemented. He got an extra time, he got a reader, and he also got a separate venue, and also routine and structure were enforced with him. He was referred to a neurologist for a trial period of medication. He started on medication and supplements, and then support strategies in the class were implemented. Just things like highlighting was encouraged for the teachers. Rudolph needed to take regular brain breaks. He was also put at the front of the class, and he was just put with one child, sitting next to one child, and away from the window, as opposed to sitting in a group of 6, where he would often get distracted by other children. His anxiety was dealt with in play therapy, a very short-term intervention of 6 sessions. Depression was monitored, but there was no other signs of depression. Came out in the counseling sessions that he was more just anxious about his work and anxious about his performance, and no stronger symptoms of depression came out. Yeah, and what was nice, what I then did from there was I used the process reports. I don't actually have a copy. I mean, I haven't actually included a copy of the process report in there, but we were able to see after 1 month, he then went back to his professor in Bloemfontein, his neurologist, and we could see that there was some difference in Rudolph's ADHD functioning. However, still with a lot of his executive functioning, his working memory, his attention, it was not optimal. So he was then put on a stronger medication, and he went back after 2 months, and the medication seemed to be working, and he seemed to be optimal, and he was performing much better in school, much better in class, and his level of anxieties seemed to drop. So that's where it's nice to be able to use the progress report, where you're able to compare. We compared Rudolph's over 3 times, so there's actually no time frame that you can use it, but obviously if you use them too close together, you're not going to see much change in behavior. But there we were able to see over a period of 4 months how his behavior did change. Yeah, so that is one example of a client that I have assessed and had very positive results using the CONUS reassessment, and you can see it's a very thorough assessment report, assessment tool, and provides a very thorough assessment report. Yeah, so that's it from my side. The next slide is just a couple of resources that we've provided for you guys. Okay, Andrea, can you move to the next one? Just a couple of resources that we've got this information and some nice information for you guys to go and have a look at. So to keep up to date with different research by subscribing to those different newsletters is always interesting. And some very enlightening YouTube videos that you can watch on that link below. And then an online course, the ADHD Everyday Strategies for Elementary School Students, also provides a lot of information on ADHD treatments that you can use for children with ADHD. Anyone have questions? Unfortunately, I had to say a lot of I think Andrea and I both had to give you guys a lot of information in such a short amount of time, but would just like to know from your side. I don't know, Andrea, is there any communication or contact that we have with anyone that we can ask questions?
I can see, yes, thank you, Megan.
Pleasure.
I can see that there is a client asking, is the CEFI limited to psychologists or can psychometrists use it? I think, Megan, you might also want to answer.
Yeah.
I think because it's diagnostic, it's also limited to psychologists.
Yes, that's correct. But psychometrists who under supervision, obviously, of a psychiatrist, a psychologist, exactly the same with the Conners assessments, they can administer, but then they just won't be able to interpret. So are limited with regards to the use of those assessments. So I would say unless you're under working for a psychologist, as a psychometrist for a psychologist, psychometrists can't use them in independent practice on their own.
Okay, and then the other question was, is the Conners Comprehensive Behaviour Rating Scale available from us? Yes, it is. I think it was Celeste who asked. The CBRS is available from JBR. I can send through the information to you after the session. Is there any other question? Anything that was unclear? Anything that you'd like more information on? I don't see anybody putting up their hand or typing a question. If you are an introvert and you mull over the information that you've just heard and you have a question a bit later on, please send through an email or give us a call. The information is on the slide below. You can send the email to info. Yeah, and then if there's anything, I think interpretation wise,
I just want to make one more point before you move on. Sorry, Andrea. I just wanted to make, somebody did ask a question about the Conners Behaviour Rating Scale, the Conners CBRS. Obviously, we said that there's a whole lot of different types of Conners, so I don't know if anybody is familiar with the CBRS. I just wanted to say that obviously that different form of the Conners, and the one thing about the CBRS is that it looks at behavioral, emotional, academic and social difficulties. So that is quite a nice scale to use either in combination or on your own. It gives quite a comprehensive rating of a child's behavior, whereas I think the Conners 3 focuses primarily on your ADHD and a slight, just a screener with regards to the anxiety and depression scales, but it isn't as thorough with the behavioral, with the emotional and social difficulties.
Okay, see, that's the value in always having somebody who is in practice who can then give you the application. Celeste indicated that she likes the sound of the CBRS, so I'll be sending through some more information. If the guys in the audience, if you'd like more information or if you think you'd like a presentation on the other Conners assessments, because there are a few in the range, please let us know. We can also see if we can put it together.
If I know, I would love to have touched on the CEFI assessment more, just because at the moment in practice, like the biggest buzzwords that are happening are all around executive functions. And I think when either you're a psychometrist in practice, or you're a remedial teacher in school, or you're a teacher at school, or you're a psychologist, everybody is talking about these executive functions. And I don't know if that is something else, but please be in touch with us at, like Andrea said, info@jvrafrica.co.za to give your feedback, ask questions, or let us know what else you want to learn.
Yes, definitely. I see Celeste also says that, yes, she'd love to have more information on the CEFI and also anything that looks at executive functioning. So I think that's definitely something we'll have a look at. Thank you for volunteering, Megan.
Great stuff.
And just,
I was going to say, just be in touch if you want details or a better description, Celeste, of that assessment or a sample report, because that also gives quite a comprehensive indication that Andrea will be able to send through to you of that assessment.
Thanks, Megan. Okay, if it seems like that's everything. Thank you again to everybody. I think the last two slides that we've got just really looks at the references Megan and I used for putting the webinar together for you guys. Some of it's really interesting, some of it's a little bit more boring, but please have a look. Please have a look at the resources that Megan also mentioned. The newsletters from, I think it was 3 different organizations, they really send out newsletters often. So they try and keep you up to date with what's happening in the field at this moment. And how the thinking is changing and what the research is doing. And it's also interesting that they are including multidisciplinary information. And it's really nice to put everything together and have a holistic view of what's happening. Okay.
Thanks, Andrea.
Thank you very much to everybody. Enjoy
Thanks,
the rest
everyone.
of your afternoon.
All right, we'll chat to you guys at the next presentation. Bye.
Okay, keep well. Bye.